Okay. Well, welcome everyone. This is actually our last online class for this session. And we're going to be talking about state minimum standards for hospice in Mississippi and Louisiana. We have with us an expert in our community, Ann Walker, who's up in Corinth, Mississippi, joining us. So I want to thank Ann for giving us of her time today. I want to remind everyone that after today's session, we will be taking roll and then we'll be sending out an email to everyone so that you can complete the evaluation and collect your certification, the certificate for today's session. And I want to remind everyone that next Thursday, we are taking a field trip to Angola, and I'm looking forward to meeting all of you there. So having said all of that, I want to turn this over to Ann Walker and let her lead us through minimum standards. Thank you, Ann.
Thank you, Jamie, and good afternoon, everyone. I'm going to present for you today an abridged version of the minimum standards for Louisiana and Mississippi for hospice care. And we know that the minimum standards are just a specific criteria defining the patient's eligibility, including the prognosis of 6 months or less if the patient and the illness follows its normal courses. Now, over the years, we've talked about diagnosis and prognosis, and sometimes that is somewhat confusing. But just to be clear and to make sure that we're all on the same page, we know that diagnosis is identification of the disease, and the prognosis is a prediction of the outcome of the disease. So CMS or Medicare, which funds most of hospice care, they're looking and they've emphasized for years that hospice eligibility has to do with the prognosis of 6 months or less if the disease follows its expected course. And that under the minimum standards, then hospice care must be provided by Medicare certified providers. And it involves the primary pieces of the care is a comprehensive assessment, a plan of care by an interdisciplinary teams. And that is the thread that I'm going to weave throughout this presentation and emphasize that it's comprehensive care. There must be a defined plan of care, and that plan of care must be developed by the interdisciplinary team. The core services, according to the minimum standards of both states, nursing services, physician services, medical social services, counseling services, and those counseling services include bereavement counseling, spiritual counseling, and other services that are needed to meet the individual needs of each family. But we also have non-core services, which almost every hospice provides. And these are services that can be provided directly or by arrangement. Those core services must be provided directly by the hospice, except for the physician. And these non-core services are hospice aid and homemaker, physical therapy, occupational speech, general inpatient care. We normally refer to that as GIP, respite care, medical supplies, and appliances, including drugs and biologicals that's related to that terminal prognosis, and volunteer services. Now, each hospice is governed by what we call a governing body, and the responsibilities of that governing body is to develop and approve the policies and procedures which define the scope of how these services will be offered. They're responsible for reviewing policies and procedures at least annually and revising them as necessary. And that governing body makes sure that there's an organizational chart that defines the line of authority for all hospice personnel and their responsibilities. This governing body must meet at defined intervals, and they must maintain minutes of these meetings. In Mississippi, the minimum standard states that the governing body must meet no less frequently than quarterly. Louisiana does not define how the frequency in which they meet, but they do define that they must maintain those meetings and who attended those meetings. The administration for hospice is made up of the governing body, the medical director, the attending physician, and the hospice administrator. And over the last few years, the attending physician has drawn a lot more attention because we know that the hospice director basically directs the hospice care for that patient. It's the medical manager for the hospice. The attending physician is the physician who has the most knowledge about that patient. Now, the patient may or may not have an attending physician when they come into hospice, and the medical director may serve both roles. But if the patient has a physician outside of the hospice, then that attending physician becomes a part of that hospice team. Our levels of care are the routine care in the home that's on a day-to-day basis. And then we have continuous home care. That is during a crisis situation when there's something that needs more hours in the home. In most cases, the general amount of time that you spend in a routine home care visit is basically an hour to an hour and a half. That's the general rule. But in continuous care, it's a minimum of 8 hours within a 24-hour period. And the majority of that time has to be provided by a registered nurse. There's also inpatient respite care, and that care is for a situation and when the family needs a rest. The patient is stable, but the family, something has happened that the family just needs a break. That way that a patient can go into an inpatient facility for 5 consecutive days just to give the patient or the family a rest. And let us be reminded that it's not about something going wrong or something exacerbating in the patient's level of care. It all has to do with that home support situation. And according to the federal regulation, respite care is 5 consecutive days. Beyond that 5 consecutive days, then a decision has to be made whether that patient goes back home or whether they need to go into another facility if the family does not feel like they can provide the care in the home. But it only provides for to be paid by Medicare for 5 consecutive days. Now, sometimes people question if that means only 5 days within a benefit period. The regulations does not say it can only be 5 days within a benefit period. It says 5 consecutive days. So there's a possibility that it could be more than one respite episode within an episode of care. And again,
And
we have the, uh-huh.
if I may interrupt you. Since hospice inside of corrections does not have these levels of care, it's all going to be basically inpatient care. And this really refers to like billing. Perhaps we can, this inside of corrections is not applicable because there's not going
Well,
to
I
be
think
there's not going to be any reimbursement.
no, but I think inside of there's no in reimburse. I mean, they're just basic a flat fee anyway inside in facilities, right?
I
Inside
know
correction.
there's not going to be any reimbursement, right, Don? There's no reimbursement per patient inside of hospice, right?
No, not
Yeah.
Okay,
Yeah. So
all right,
so
but
in terms of billing issues, I think perhaps for today's sake, we can leave out anything that has to do with billing in terms of the
okay,
minimum,
but
understanding the minimum standards.
okay, and I'll move beyond that, but I just want you to consider this. It
Mhm,
may have to do what you may be able to use this rather than looking at it as a billing issue. Look
mhm.
at it as an acuity of care issue
Yeah,
of
yeah,
identifying how you classify that patient as to where they are in their episode of care, how
yeah,
sick they are.
yeah.
So you may look at that. That's just
Yes,
something
ma'am.
for, something you
Yes, ma'am.
can think about
Right,
because that way all patients are not all at the same level at the same time.
right,
So if
right.
they're if they're rarely stable, you may say, well, this person is in the routine
Yes.
care class.
Okay.
If they're needing more care, you may say they're continuous care, where you're having to put more staff
I
with
see.
them for a longer period of time. So it may justify your staffing if you look at it that way.
I see. Okay. Thank you.
Okay, and the staffing again, this is the general makeup of the staff. You have your medical director, your nurse who coordinates the care. You have a social worker. In Mississippi, the social worker can have a bachelor's degree and 1 year of clinical experience, but in Louisiana, the social worker must have a master's degree. And then there's the chaplain, the hospice aide, and the volunteers. And I think in the correctional institutions, volunteers play a large role in the care of the patient. Isn't that right?
It will. That's the point. That's
Okay.
our point.
Okay. And as for the interdisciplinary group, it's made up of all the people who's involved in the care of that patient. And it should, at the minimum, be a nurse, a doctor, a social worker, and pastoral care to provide bereavement and counseling services. And again, that whole group is responsible for participating in the establishment of that plan of care and supervising that care throughout the time that that person is on service. And that plan of care is to be reviewed periodically, and according to the regulations, it's to be reviewed every 2 weeks to make sure, to evaluate where that patient is based on the goals that were set for that patient when they were admitted. The interdisciplinary team is also involved in the establishment of the policies and procedures and the day-to-day provision of the care. And I've already said that they meet periodically, usually it's every 2 weeks or every 14 days, to evaluate the care needs and to update the plan of care. And patient certification and corrections, do the patient sign an election statement? Do they do that? Do they elect the hospice care? Okay, well, the election statement, uh, okay, the election statement outside correction is when the patient determines that they are electing the hospice care and they're giving up their other Medicare benefits in regards to that terminal disease process.
Right.
They must be certified as terminally ill by a physician based on that prognosis that we talked about earlier. And then a plan of care has to be established before the services are provided. So an assessment has to be done by a nurse, and the regulations say uh, within 48 hours of the time that the referral is made. And the nurse goes in, she does an assessment to identify the immediate needs. What's actually going on with this patient? What are their problems? Are they in pain? Do they have nausea? Or what exactly is going on? And then they then come together with other members of the hospice team to say, I made this assessment on this patient. These are my findings. And then they together come up with that plan of care. And then within 5 days, then of comprehensive assessment, that means that everyone who's going to be involved in the care of that patient, the chaplain, the social worker, and the volunteer, anyone else who's going to be involved in that care, they come together to discuss that plan of care to say, I've made my assessment, I've seen the patient, this is what I will be doing to the patient, and that all comes together as one comprehensive plan. And then you develop, okay, you've got your plan as to what your interventions are going to be. Now you need to decide, what are your goals going to be? What are we trying to accomplish? Are we trying to decrease the level of pain for this patient? Are we trying to eliminate their nausea and vomiting? Are we trying to deal with their coping as far as this terminal diagnosis and dealing with their disease? Or do we need to, I don't know how it plays out as to support systems coming into the facility. Is there issues going on there that needs to be addressed? If those are issues, then those become part of the goals as to where we want to be. And then at some point, then you go in, when you do these care plan updates, you say, okay, so when we admitted this patient on this day, they rated their pain at an 8. We said we wanted to get down to a 2. But in 2 weeks, we've got it to a 6. So we've made some progress, but we haven't made our goal. So we established new goals and said, now we still want to get it at a 2, and goals are not completely met. So we're working on it. So you're actually you're looking at your progress toward goals. And ideally, you want to meet those goals at every time point, but realistically, that is not going to happen. And that's okay, because you're moving toward meeting those goals. And I always say that on every plan of care for a hospice patient, one of the goals should be a good death. But again, what does a good death look like to that patient? Where do they want to be? How do they want to die? Do they want to die? They want to be alert until they die? or they want to sleep through until they die. That's a conversation to be had because some people just want to go to sleep. But other people, I want to be here. I want to be alert. I want to know everything up until the last time. And again, that is a conversation that needs to be had. What does the patient define as a good death?
Might change over time as
Right.
the patient progresses. That conversation is an ongoing conversation, in other words.
Absolutely, it is. And again, the admission procedures, of course, you're going to get a copy of this PowerPoint, but it outlines what the things that you need to have in place, the consent forms, the patient's rights statements, the physician's order for care, the equipment that's needed for this patient, and then an orientation of the patient and the caregivers about what this person wants, their advance directives, their what services will be provided, even within the correctional facility. What can you provide and what are you going to provide? Because if you have people that are in corrections and they have been out in the community, you don't know maybe that they have had a prior hospice experience. So you may not know what their expectations are. So because you say, well, we're in a correctional facility and this is what we do, so we assume that people should know what it is that you get in the hospital, in the correctional facility. But people don't know unless you tell them. So we shouldn't assume that people know anything unless we make it clear to them and what their rights are. And and again, we say the certification of terminal illness by the medical director. We talked about the comprehensive and the initial assessment, and the bereavement assessment is part of that initial assessment within those first days. And that is, how does the patient deal with what is approaching? How do they deal with their terminality? What has been their experiences? What are their religious preferences? How are their coping skills? That is very important as part of that process. And oftentimes we think that, well, bereavement only happens after death, but it's not. It's part of that journey where the patient is at the time of admission. And again, during the course of care, that will change more than likely. Their needs and what they feel like and what they want done. And again, the plan of care is the guiding document as to how you take care of this patient. And it's written and it should be individualized. And I know that we use checklists and we have standard procedures and we have standard protocols, and that's good because that's guide us. But once we look at all those things, apply it to that patient or how it applies to that patient. Now, what sets this patient apart? What are their needs in addition to what we have identified as an organization as the best practices for taking care of this patient? So we take that full picture of that patient and we individualize that plan of care to meet the need. And we communicate that to everyone who's involved in that care of that patient. Uh, and again, equipment that's needed, medication that's needed. And oftentimes, patients have been on certain medications, but when they get to the point where they're no longer seeking aggressive treatment for whatever it is that they're dealing with, there may be some medicines that you may want to deprescribe. Uh, if a person has been on blood pressure medicine for years, but they have lost weight, they're not eating, they're not drinking, and their blood pressure has been running almost hypertensive for weeks, then have a conversation with a physician and say, does this person really need this blood pressure medicine? I know they've been on it for the last 30 years, but do they really need this medicine? And you should have a formulary to look at the medicines. And hospice is it's about providing cost-effective care. So you shouldn't be giving patients the most expensive medicines that's out there, but you should be giving them medication that are effective enough to control their symptoms. And the plan of care must be maintained in the patient's file. You should be able to look at that plan of care. Any person should be able to walk up and look at that plan of care and say, this is what I need to do to that patient. They should be able to look at the documentation and say, this is what has been done for this patient. Again, it should be reviewed at a minimum of every 14 days. And, and of course, in corrections, you're probably going to review it more often than that. I don't know how often your teams meet, but when your teams meet, you need to look at how this person is progressing based on what you have said need to happen with this patient. I'm going to run through the discharge because I don't think those are issues that you would be discussing. And the clinical record, just on the safety side and the legal side of clinical records, the person who does the assessment or the person who provides the care need to be the person who does their charting. People shouldn't be charting for someone else. You need to do your, that individual need to do their own charting. And the clinical record should be complete as well. So this, I think, will be important to corrections because you don't need to take shortcuts here. You need to have the initial and the subsequent plans of care along with the initial assessment, the physician's statement of the patient's terminality, their orders, any clinical notes, at least those of the last 60 days, the plan of care, any signed consents, their medical history, of course, their demographic information identifying who they are. And again, I'll say that the entries in the record should be signed by the person who provided the care. And legally speaking, again, this is a billing issue for those of you who may be working outside of the correction, is that the orders have to be signed before you submit the bill to Medicare. There should be policies and procedures, and these policies and procedures should be reviewed annually. Who should they be reviewed by? Your governing body and your interdisciplinary team, and they should be approved by both of those groups. And they should address your personnel standards, the qualifications, your patient care standards, your purpose and goals of what you're doing, why you're doing it, and how you do it. And it should include your formal disaster plan. For hospice employees, they should be safe to take care of patients. They should have, if they are required to have license, their license should be good in good order, and they should be checked to make sure that they're current. And the health screening, the TB skin testing should be done according to the Mississippi State Department of Health, and there should be a screening just of the health condition of your employees. The staffing, I'm sure you define that, but it should be defined, it should be in writing, and it should be developed at least a week in advance and updated as necessary. And it should be kept wherever the care is being provided as to who the person is, what their assignment is, and what patients they will be seeing and during what hours. And if you have aides or LPNs operating in your organization, then an aide should be supervised by an RN, an LPN should be supervised by an RN, and if you have therapists, they should be supervised by uh, therapy assistants. They should be supervised by the therapist. If you have a PTA working, then they should be supervised according to their guidelines. And if you have an occupational therapist, they too should be supervised according to their standards of practice. So you just want to make sure that even though you're in corrections, even though you're not billing Medicare, you still want to make sure that you have all your bases covered. And when it comes to education, most patient care providers are required to have at least 12 hours of in-service education. And that's an easy one. You're doing infection control, you're doing basic hospice care, you're doing safety, you're doing fire safety. It's 12 hours of in-service education annually. And if the person is part-time, if they're part-time for the full year, they're required to still meet that 12. But if they work less than a year, then you prorate it based on the amount of time that they have worked. In Louisiana, all healthcare providers are required to have at least 2 hours of continuing education, and that's where they get CEUs for what they're doing. So that's a step beyond just the 12 hours of in-service education that may be intradepartmental. Now, performance improvement and quality assessment is really important. You know, there's a saying that says, what gets monitored improves. So we need to monitor what it is that we're doing. And this is ongoing, it's comprehensive, it should be integrated, it is a self-assessment, and the purpose is to improve whatever it is that you're doing. And um, and it's written. There are policies and procedures explaining how you do it. You explain what it is you're going to monitor, and it should include the goals and objectives, who's responsible for doing it, or who's responsible for what, and it should be systematic, and it should be objective, and your documentation should be such that you are able to pull those things from your documentation. For example, I talked about pain. You may have a QAPI project that said patients will receive will reduce pain by 4 points within 3 days of admission. That's very succinct, and it's easy to pull that information because you only basically have two data points. What was their pain on admission, and what was their pain in 3 days? So you collect that. And then if it's not there where you want it to be, then you can look and say, well, was this an unrealistic thing in the first place? If you have no patients that meet that goal, then obviously it was not a realistic plan, but that's okay because it is about continuous improvement, looking where you are, where you want to be, and where you can be. So oftentimes people see that as intimidating, but it's really not. It's helpful to the overall organization. And I know those of you who are on this call, I know that you share this thought with me is you think that you're doing right until somebody tells you that you're not. And that's human nature. How do you know that things are not right unless somebody brings it to your attention? So it's good for you to talk to your staff about the importance of assuring that you are providing quality care. And you only know that by looking at yourself and looking at objective data, not something that somebody thinks. It's based on the facts. And it's just really important that you do that. So your quality plan should be reviewed at least annually. It should be shared with those two main groups that I told you about, your governing body and your interdisciplinary team. They should meet regularly. You should have a cooperative committee that meets regularly, and you should work on your plans together. The final thing that I want you to take away from this is that when regulations conflict, the rule of thumb is the most stringent rules apply. I have discussed with you some of the minimum standards for Mississippi and Louisiana, and those are licensure rules. And that's the very least of what should be done for licensed agencies, but we also have the federal conditions of participation. Most of the time they line up. You can just lay one on top of the other one and they'll be exactly the same. But there are times when they differ from each other. And when they differ, the one that's the most stringent is the one that you should adhere to and the one that you should implement. My disclaimer here is that I recommend that you review the specific minimum standards for your respective state because I have not gone into detail on every item, and the links to the Department of State minimum standards are on the front page of this presentation. Are there questions? Any questions?
Anyone can, you can unmute yourself and ask Ann a question. What I would add to Ann is that the minimum standards in Louisiana and Mississippi for licensing, you have to remember, are based upon whoever pays the bill gets to make the rules. So, in order for most of hospice in Louisiana and Mississippi is either paid for by Medicare or Medicaid, and these are the community standards that are set by Medicare and Medicaid to
Guide
if
how
you
hospice is done.
exactly if you want to be reimbursed, you have to meet these minimum standards. Um, uh, and but it's theoretically it's possible for a hospice company, and I'm just thinking off the box here, off the top of my head, it's possible if a hospice is not receiving any federal or state money, Medicare or Medicaid money, they couldn't be licensed. Well, they would have. I know that there are what we call volunteer hospices in the country. There are very few of them, but they accept no money whatsoever. Do they have to abide by these same standards?
No, they do not.
They do not.
But
They,
but you might want to do close to it though. Now, some of the, these time frames,
uh-huh,
you would not have to do that, but from a legal perspective, you would probably want to provide, you probably want to go close to these standards because
right,
you're saying that is the kind of care that you're providing. And
right,
this is the standard care. Now, we're
right,
not talking about, like you said, the payment issues, that's one thing. But the
right.
care issues, you want
The
to go
care
by
issue is another
those.
thing. Yeah.
Because
And,
to not do that would indicate that you're providing substandard care. Like in
yeah,
the staffing issues, and we talked about how you need to make sure that your staff is screened for health and you do the background checks for your staff.
right,
Those are the kind of things that you would want to do,
right,
even though you were not a Medicare provider.
right. And Don, when she was talking about the governing body, I guess that would be some sort of combination between Vital Core and MDOC that would get reports from the various facilities that are doing hospice, um, giving them a quarterly update. I don't know if there's such an entity that now meets, you know. An integration between VitaCore and MDOC on any type of regular basis in terms of the overseeing of the entire health services that y'all provide. But that would be considered the governing body for corrections in Mississippi.
There, there is the American Corrections Association, which accredits the correctional facilities, which includes the medical care that is provided within the facility. Also the NCCHC, which is another governing body and which is an accrediting agency as well. Many
Which one does Mississippi, they
We're-
use both of them?
covered by both,
Yeah, both.
and are accredited by both.
Mhm.
Well,
Is hospice contained in either or both of those accrediting?
there is, I know that hospice is addressed by the ACA. And I'm fairly sure that it is also addressed in the NCCHC. So
I think,
we will be meeting, we have regular meetings that in
mhm,
both the medical staff as well as the corrections staff at each of the facilities. And what I'm seeing is probably a hybrid of those groups that will function on a different level, but if essentially that hybrid group will act as the governing body, and we will have, of course, we will have members of MDOC, we'll have members of Vital Core as the interdisciplinary care team. So we'll be, we'll be working within those guidelines to make sure that these standards are met.
in other words, you
Now,
could see how that would fit with your current structure.
Don, let me ask you a question. Now, who did you say you were going to have as your interdisciplinary team?
We will have the site medical director. We will have nurse practitioners who will be providing care, as well as the physician, the site medical director. We will have RNs And we will have a supervising pharmacist. We have a state medical director as well, who will have kind of a oversight overall. We have the superintendent of the facility, the assistant superintendents, the wardens, who will work within that team, to make sure that we are meeting the guidelines. We
Now
have,
that, what you just described sound more like your governing body.
well,
When you added those last few people, because your interdisciplinary team are going to be your care providers.
we'll have social workers, we will have mental health professionals, we will have RNs, and we will have the volunteer, the inmate care providers.
You have medical directors at each of those facilities, correct?
Yes,
And you will have one RN that you will appoint in each facility to head that up, right?
that's correct.
Because you will have, sounds like you will have several interdisciplinary teams.
Well, we'll come together as one. We'll have one that will meet to discuss the care planning, to discuss the progress of the patient, and will function as the interdisciplinary team. Yes.
Uh,
Now,
uh, you will have one in each facility, is what you're saying.
correct.
Yes. Okay. And then Ann talked about, we call them QAPIs, but a lot of healthcare facilities have implemented performance improvement projects where they look at different issues in their delivery of services to see where improvement is needed. Do you all do anything like that currently in terms of have a have a model for
We have
identifying and identifying issues and having providing resolution for those issues?
Vital Core has a very robust QAPI program.
Okay, so you're familiar with QAPI as well. Good. Okay. Okay. I wasn't sure if that was just a hospice term or because I said it with a home health recently and they didn't know what I was talking about when I said QAPI. I was like, okay, performance improvement projects.
Quality assurance, performance improvement. Yes, we have a very strong QAPI program in place with with monthly areas that are identified, chart audits, and then you respond based on how you meet those audit guidelines. You set your action plans, everything to make sure that you're addressing those, and those have to be documented as well.
I think people in healthcare have a general idea about what constitutes good care and good practice, best practice, and that's what we're trying to bring to hospice as well throughout the Louisiana and Mississippi, but especially in these unique situations like corrections. And we now are seeing hospitals open up inpatient hospice units. That's a whole new ball game as well. So these are all innovations that Ann and I were talking about earlier in the future, and maybe even in corrections, we'll have devices for folks that will give us immediate readings and things like that. That will that will augment the way care is being delivered. But in corrections, it's very much hands-on. I mean, it's almost like an inpatient unit that we're talking about without the inpatient reimbursement.
We're basically going to be having routine care
Right.
and GIP.
Mhm.
Actually is what we're looking at, uh, for, all of the patients that we care for. And Jamie and, you know, one of the things, and you have seen it from the outside, I've seen it from the outside as well as the inside, and that is a very pronounced and pervasive attitude in the communities that things within corrections are less than. And I feel like it's very incumbent upon us as caregivers in the hospice program, um, and in corrections overall, that we rise above that and that we provide the absolute best level of care that we can provide for those patients who are approaching the end of life.
First of all, as I said, I think in the very first session that we did, um, the volunteers that you're going to be working with, they're going to know authentic care from non-sincere care, and that information is going to permeate throughout your general population, whether the care is good care, whether hospice care is a good thing, or if it's just another failed service inside of corrections. It is incumbent to provide good care in order to stop the lawsuits.
You know,
Right,
it's one thing for a hospice unit to have the reputation of being an end of life unit.
Right.
Certainly an absolute diametrically opposed to have that hospice unit have the reputation of being the death unit.
right.
Right.
And that's a hard one to get away from too, because you
Right.
probably 99% of your patients die.
Absolutely. And,
Mhm.
that's one of the things I think, like I said, it becomes very incumbent upon us, if we're going down this road, that we've got to make sure that we are open, above board, transparent, and that we are providing the best quality care that we can.
And
Exactly.
Don, I don't know if you have done this or not, but I think this would be invaluable for your leadership to be familiar with these minimum standards. So
Absolutely.
you
Mhm.
will know, or they will know, what is different with the care that you're providing and what these minimum standards say. Because when they're talking to people out in the community and they have had hospice care, they may ask a question that your leadership may not be able to answer because you may be providing something a little different because of the way that you provide care in institutions, and people don't understand that. Because we know and you know that it won't be exactly the same, and that's acceptable. But when you get out in the community, that's what caused some of that gossip. Well, my uncle was in corrections and he didn't get this, you
Right.
know. So if your leadership knows the difference, am I making sense what I'm saying?
Absolutely.
Okay.
And I think, our experience, at least with the 5 facilities in Louisiana over the past 20 years that they've been in operation, they've been seen as an asset to the facility in all sorts of ways. They have great reputations among the volunteers, among the general population, among the staff at those facilities, and you don't see the litigation. You don't see litigation about um, you know wrongful deaths or anything like that. And I'm hoping that that's exactly what we can help bring to to the Mississippi facilities as well. Is that sort of reputation?
I think it's a wonderful thing that Mississippi inmates can have this benefit. I think that's a
Yeah.
wonderful thing.
Yeah. Um, are there? We've been talking a lot. Are there any questions that anyone on today's call actually have for Ann or for Don or for myself? or Marquetta is also on today's call.
Well, we appreciate your attendance, and if there's any, Don, you know how to get in contact with me. If there's anything that I can do to help you, just don't hesitate to call.
I can find.
Thank you. And again, I want to thank you all for your time and attention over the past 11 weeks. I want to especially thank the Franciscan missionaries of Our Lady who have made your continuing education credit possible throughout this entire series. I look forward to meeting all of those who will be traveling to Angola next Thursday. I look forward to meeting you there in person. Right now, I would ask that if you would be so kind as to put in the chat box your name and your email address so that we can record that, and within 24 hours, you should see an email pop up in your inbox giving you a link to an evaluation of today's session that you can complete, and a certificate will appear in your online profile on our website that you will be able to draw down whenever you need that documentation. If there are no other questions, or Don, do you have any comments before we close up today in terms of instruction for next week?
I just want to say, Jamie and Marquetta, all of you who have participated in this, thank you. We really appreciate it. You've done an outstanding job. You've been very professional, very well grounded in your knowledge, and I have had many comments come to me about how good a job you've done. So we appreciate that very much.
We hope this is helpful. We hope that this is a helpful springboard into the reality that you all will find yourselves as you launch into hospice journeys with the inmates in your care. And we want you to know we will be here to support you through that mission in the years to come. So whenever there's a need or a question, you can pick up the phone and you can contact us, and we will connect you. I certainly don't have all the answers, but thankfully, I know people like Ann and Marquetta and people across the country that we can contact and get information. So don't ever hesitate to reach out and say, I have a question about this. We will get you an answer. Or sometimes it's many answers that we actually provide, difference of opinion. So we thank you all for being so attentive, and I look forward again to seeing you. Please put your name, make sure your name and your email address is in the chat box now. And with that, we'll say adieu.
See you next week.
Thank you.
Thank you.
Bye-bye.